And that was actually even a big point of emphasis. The head Secretary of Health and Human Services, Alex Azar, spoke to us, and amongst the other kind of talking points of what the president has put forth of short-term medical plans and association health plans, and we'll talk about those a little bit on our level. I would tell you at least half of his speech focused on some ideas to control the cost, specifically prescription drugs, durable medical equipment, and a few other items. And so that was really refreshing and good to hear. I would note that as I was sitting in this conference, listening to kind of both sides talk, or different people talk, I also had a copy of Politico, which is kind of the local DC magazine that if you're at all into politics, you read this on a daily basis. And what I found very interesting is there were 8 full-page ads in Politico that day, and 7 of the 8 had to deal with healthcare. One was Big Pharma saying that the kind of their value proposition of what they're doing, and that the real problem of why they're so expensive is the PBMs, pharmacy benefit managers. And then the next ad was by the PBMs saying that Big Pharma was the problem. And then the next one was, a group of doctors saying, who is the problem. And so I guess my point is that is very much the sense of what's going on at the United States Capitol is healthcare. And so everybody who is involved in it is really trying to kind of explain, we're not the problem, here's who's the problem. And on Tuesday, I forget, it doesn't matter, Monday or Tuesday of that week, they were actually bringing in a lot of the executives from kind of the big pharmacies in the country, and grilling them, talking about, what's going on, why is this so expensive, and what's happening. So it was a very good time to be in DC, although the weather stunk, although it wasn't, I guess, snowing like it has in some years. But as far as the content of the representatives and the senators and what they wanted to talk about, healthcare was a big issue. They wanted more information. They wanted to know what were some practical solutions to our problems. And that kind of takes us to our next slide. So one of the things that we do for NAHU, which is the National Association of Health Underwriters, is we actually go and lobby. We meet with our different representatives, and we talk on specific points. And this is just kind of an example of 2 of the meetings that either Ned or I went to with Representative Ami Berra, who kind of represents the, I would say, East Sacramento area, kind of Citrus Heights, Fair Oaks, all that area down into Elk Grove a little bit. And then Republican Tom McClintock, who is kind of Placer County, El Dorado County, kind of the east side of the state. And so most of us on this call, probably these are our 2 House of Representative members, and these were the actual talking points we used on them. And they were very receptive. And typically, I got to tell you, these 2 are pretty good to us every year. Oh, and my computer just decided to stop working. That's awesome. But anywho, on the next slide, I did want to kind of talk about some of the specific things that we did review with them, because I think they're pertinent. And you see here, this is kind of a zoomed in version of what our talking points were. And you see that really what our goal was to do is reduce the cost of care and improve kind of the pool, the market for both individual and employer-based coverage. And so I'll just kind of talk on a high level without getting super into this, because I'm sure not everybody cares. But one of the things that we are advocating for are these high-risk pools. Let's start putting a cap on the risk that the insurance companies have, for the really, really sick people. And at a certain point, the insurance companies stop paying, and then the federal government would pay. We believe this is kind of a common sense approach that in turn would reduce the cost that you and I pay for a health care. And it varies on what they believe, if we reinstitute these federal high risk pools would look like, or what it would mean to us. But I've heard anywhere from 5 to 20% being able to lower the cost you and I pay on a monthly basis. And if there's questions about that specifically after the fact, we'll kind of come back to it. Okay, but I'm going to stay a little high level right now. We also talked about, the excise or Cadillac tax. If you aren't aware of it, originally in the ACA, starting in 2018, it was when that specific tax was supposed to be implemented, and it has been kicked back. I would say that the can has been kicked down the road 3 times, and as it sits currently, I believe that tax is supposed to start in 2022. And basically what it says is, if you are spending more than, I'm going to give you a rough number, $10,000 a year on healthcare, then they're going to tax it at an additional 40%, which is just asinine. And it was originally going to be for those Cadillac high-end plans. The problem is that there are now people who $10,000 a year, if you are 63 years old, that's a bronze plan. And so that tax would say you would, because you're on a bronze plan that costs so much, we're going to tax it at an additional 40%. So even though that keeps getting kicked down the road, we have been asking for just take it out. Let's stop messing with it. Ultimately, if it ever comes into play, it's really going to hurt people. We believe that the employer-based system does work very well, and we want to make sure that the amounts that businesses pay towards the coverage of their employees, that we want that to continue to be excluded for your taxes, because there is talk about switching that. And so we're there lobbying it, explaining why it's a good system and why it works. And then the other big one is balanced billing, which I do think we are probably going to see legislation introduced this year on this whole surprise balanced billing. I hope you have never had to deal with this, but there unfortunately are cases where, if you are a member of, let's say, Anthem Blue Cross, and that Sutter hospital you're going to is part of the network, and let's say you get in an accident, you are unconscious, you're taken to Sutter like everybody is supposed to, and in the ER, a doctor touches you, a specialist, let's say, who is not part of the network. And you will be charged for that, as a balanced bill after Anthem kind of pays out what they're supposed to do as their contracts. And people get balanced bill without any knowledge whatsoever or choice. And we believe that is a bad, horrible thing. And California has passed some legislation to prohibit that to an extent, but where the California law still falls short is in the case of emergencies. In cases of ER, those out-of-network doctors are still allowed to bill folks in California, and so we're asking for that to be fixed on a federal level, and I do believe that there is support from both sides to get this done. So again, I'm going to kind of stop there on the specifics. If there's specific questions about what we were lobbying on, we'll come back to that after the fact, but let's go ahead and keep moving on here.
Well, yeah, Dave.
Yes, Ned.
Yeah, so I'm going to start talking a bit about the legislation at a state level. But before we do, if anybody has any questions on the federal side, please type your comments in the chat box. But I'll just agree with Dave. In going into these meetings the past 6 years, a lot of times, we'd be speaking to a Republican and they would not want to do anything to fix anything because they wanted to repeal and replace. And now going in, there is definitely more of an agreement, just between the parties, at least verbally hearing them, that they really want to fix this, because I think we've all seen the costs continue to increase. And I'm sure that they're hearing it from their constituents. So there's no questions typed in at this point. So I'm going to go ahead and move from a federal level to a state level, because we have some, with the new governor, there's some new things on the horizon that you'll want to be aware of that may or may not affect the benefits that you offer your employees. Okay, so when Governor Newsom came in, and Dave, feel free to jump in anytime, he created his executive order, and one of the things, this kind of third little arrow here, is to create the first in the nation single purchaser of prescription drugs. So this is very interesting because the conversation has been around single payer, and now when you look at his executive order, the conversation from single payer has moved to a single purchaser, and for this first item of prescription drugs, which really would be a great thing because the prescription drugs is really a big driver of our healthcare. Families have seen their prescription costs double since 2000, and I know, we hear from our clients regularly the cost of prescriptions. And so if we just go down, the idea is that state agencies will now purchase prescriptions together with the hopes of creating more purchasing power and then possibly creating an opportunity. And I don't know what this would look like, but this was kind of in his language of creating opportunity for businesses to be able to sit at that same table and negotiate the prescription costs. The second bullet is to increase the age for undocumented workers to have access to Medi-Cal. So currently, undocumented youth are termed from Medi-Cal at age 19, but to be similar to when youth are kicked off of your traditional small and large group plans, now he wants to increase that to age 26, which you could argue either way whether that's going to increase our insurance premiums or not, or I should say small group, large group premiums. Right now, if you have somebody go in that does not have Medi-Cal at age 21, then there's costs the hospital are accruing without any kind of insurance to be covering that. So Dave, do you have any comments on that bullet point before we go to the next slide?
Yeah, I would tell you that I think that we're probably going to see that there's a good chance it's going to pass. I know a lot of people have a political opinion one way or the other on that, but I would tell you that I would think that if we have more people, young people on Medi-Cal who are currently not insured, it should help us at least in a small amount on the health, or those who are buying health care themselves, because right now they're getting care without any reimbursement, and this would make it so that they are getting it through Medi-Cal, and that would ideally lower the cost to us.
Okay, so the next thing that Governor Newsom wants to do is expand the Affordable Care Act's financial assistance to middle-income families. So this is interesting because, most of you on the call are small to mid-sized business owners who are offering health insurance. Now, if you offer health insurance, then your employees, your staff is not eligible for the tax credits through Covered California. So in California, it's Covered California. So if you look at this, it would expand the opportunity for people who do not have health insurance available to them. But currently, an individual making less than $48,000 and a family of four making under $98,000 will receive some kind of subsidy or tax credit towards their health insurance premium. Governor Newsom would like to increase that to $72,000 for an individual and $150,000 for a family of four, which really would open up for a lot more people who would be eligible, clearly, to go through Covered California, because in our state, right, we're much higher than the federal poverty level, which is what the standard is set by. And so if that was raised, it would open more opportunity for individuals, which if they work for you and are eligible for your benefits, they're not eligible for that tax credit. So we could find employees who are saying, hey, I don't even want benefits because I could get this. However, we are seeing that currently the cost of individual insurance is more expensive than through the group plans. The other thing, though, is we don't know what the subsidy will be. The subsidy might not be as significant as what people are currently getting. So the contribution from the employer may still be higher than what the individual could get from Covered California as a tax credit. Second bullet point is to do so, California would have to then implement a state individual mandate. So with a penalty for not participating. So as we know, this 2019, the penalty is no longer there federally for an individual not to have health insurance. The law is still there. The law couldn't be changed, but the tax could be changed. So there's no penalty on your taxes for not having an individual plan federally, but to implement something like this, Governor Newsom would have to put in place legislation with an individual mandate with a penalty. And we're not sure what that penalty would be, but it would, to cover the cost, it would have to at least be what the penalty was originally, which is $696 per member of your family, well, per adult, and then it goes down per kid, or 2.5% of your income. Dave, any comments on this before we go to the next slide?
Yeah, I do think this is going to happen. I know Cover California is making a strong case for it. I do think it'll be at least what the federal side did, if not more. But I will also tell you that subsidy we were just talking about going up all the way to $150,000 is directly tied to whatever they get for that penalty. And so that's kind of the big question is, okay, well, how much money are we going to get for that penalty? And then they will, depending on what they bring in through the penalty, is how much they will then agree to kind of subsidize the plans. And what I've heard initially is that it probably is not going to be a huge amount. Like somebody who is at the higher end of the $150,000 and then, you know, technically qualify for the subsidy, it could be as little as like $28 a month. So we'll see. It might be a much ado about nothing.
Yeah, I think the only thing that really affects the business owner or the small business is that if this were to go in place, then you may see more of your employees who actually, if they're only going to get $28 a month, because they're more of a middle class wage earner, is that you may see more employees want to join your health plan. And so, or even add their families to it if they're going to have to pay a penalty for not having their family on the plan. So we may see an increase of employees wanting to join the health plan. Okay, we can go to the next slide. Okay. Something interesting is this first bullet point is Governor Newsom introduced a state surgeon general. And this is, I think, just kind of continuing with what we were seeing on a federal level, is that it's changing the health insurance and making health insurance a mandate didn't make it less expensive. It made it more expensive. The root cause is health care. And so you'll see this. We have a state surgeon general now addressing the root causes of serious health conditions and to look at the cost of health care and how can this be lowered? What can be done to help lower the cost of the care, which would then drive down the cost, drive down the cost of health insurance. This is what you're seeing here is, from the office of the governor, a letter to President Trump, majority leader, and to them asking for additional waivers to be able to be more of a leader in the United States as far as trying to move towards, and the language is more universal care, not single payer care, which we'll talk about in a moment. But Dave, anything that you want to comment on the state surgeon general or the waivers that Governor Newsom is requesting?
One of the waivers that he's requesting is to be able to implement single payer. We believe that that's really just kind of throwing a bone towards the ultra far left side that wants single payer, and that everybody knows that they're not going to get that approved. But they are asking for some other waivers that is trying to be kind of make California a leader in getting the goal of universal coverage. And I know you're going to talk about this in a second, rather than government-run coverage. And then as far as the Attorney General goes, we think it's really somebody who on the state level can focus and talk about how do we control the cost of care at our level? What do we have power over and what can we do?
Thanks. You can go to the next slide. Okay, so Dave, why don't you speak to this piece?
So, you know, in other times we have talked about single payer. You know, it was introduced as SB 562 back in 2016. That was a big political fight, lots of intensity and everything else. And it is interesting that now that they have, you know, the governor who signed on for single payer, the head of the California Senate as one of the authors of the single payer bill, the insurance commissioner as the other author or a co-author of the single payer bill. Basically everybody who said they were pro single payer and really wanting this are in charge of the state now, and yet we are not going to see a bill introduced this session for single payer. And I would tell you, I interpret that to mean that it was more of a political show, saying, yes, we support it. And now that they actually have the power and all the people in place to do it, no, we don't really want to do it, and don't introduce the bill because we don't want to have to go on record saying yes or no, now that we really do have the power to implement it if they wanted to. So I think that's kind of a big deal. And I think it's a pragmatic approach from the leaders in California to say, that's not going to work here. What else can we do to accomplish the goal of universal coverage? And you kind of see there below, single payer versus universal health care coverage. And those words are a lot of times used to be or thought to mean the same thing, but there is a significant difference. Single payer is government run, and the government pays for all health care. All the doctors and hospitals in the state would be employees of the state, and they would be in charge of all things healthcare. And that is significantly different from universal care. What universal care is basically saying that everybody is covered through a public and private partnership. And most of us in the state would agree that universal coverage is something that we want. We want everybody to have some type of coverage or access to some type of coverage. Most of us would probably still agree, even in this state, that having the state run everything is not really what we want. And so, again, trying to find the positive in what I'm reading the tea leaves is, I think, again, they're being pragmatic and realizing that some of these things that the far left of the party might want are not practical, and what are some solutions that will actually help people and can be accomplished. Ned, I don't know if there's anything else you want to add to that, but that's kind of what I'm seeing by the fact that that bill is not introduced in this session.
Yeah, no, I think it might be, maybe you could speak just for a second on what Newsom did in San Francisco, which might show, you know, kind of his approach, because, I mean, he created universal coverage in a sense in San Francisco.
Yeah, and again, that has been kind of confused a little bit, especially when he was running in the primary for governor. Because what the model in San Francisco, for those who are not familiar with it, is that everybody was supposed to have coverage, and all businesses were supposed to provide a benefit to their employees. And the businesses had a choice of either providing a basic benefit to their employees, or that equated to a certain dollar amount, essentially per hour paid to employees, or if they didn't provide those benefits, that the equivalent amount would be paid towards a fund in the city. Most employers kind of realize that, okay, if I pay for that benefit for my employees, that's tax deductible. Whereas when they're paying into the fund, it is not. Similar to what is being done on the federal side in the employer mandate for those who are applicable large employers. And so everybody in the city of San Francisco is either being offered coverage through their employer that is considered, affordable and credible. And for those who aren't, they pay into a fund so that there is a clinic slash, I don't know if it's a true hospital, but it's at least a clinic in San Francisco that's how they pay for it. And it's essentially free and open to any resident can go to that hospital and receive care. And the funding is coming from those employers who aren't paying for the coverage themselves, and any individuals who don't have that coverage. So it is everybody in the city of San Francisco, essentially, if they don't get that coverage through their employer, can go to this clinic for free and receive the care they need. And so, I don't know if I don't think that model can be used on a statewide level, but that is what the San Francisco ordinance did. And, I guess we could say he's accomplishing, or that they were able to accomplish universal care. Everybody can at least go to that clinic and receive care. They have access to it. But I don't know the feasibility of that working on a state level as big as we are. And,
Dave, let me ask,
go ahead.
Dave, this, because a question just came in, and what would have to change in California for universal coverage? Or do you feel like that's already available now?
It's pretty doggone close. In California, the number is... And
so let's just repreface this with, let me just repreface this. Universal care is that everyone has access to getting care, where single payer is government-run health care. So it's different. So the question is, does everybody have access to health care, which is universal care in California?
Currently, no. There's not an individual mandate, right, that saying everybody has to be responsible and go get it themselves, although I think that's about to change. And nor is there an employer mandate on the California level. There is on the federal side. And I guess that would be a question that I have not heard yet presented. Is California going to do an employer mandate for those below 50? Because you remember, 50 full-time employees is what the federals make you an applicable large employer and you have to provide. Would California do the other side of that and below 50? I have not heard that they're going to do that yet. Not saying it won't happen. But then, assuming, let's just say that we have an individual mandate and then we have a employer mandate for all employers in the state, then what? I don't see the government taking over any hospital system or doctor system. So what's the next closest thing? Medi-Cal. Medi-Cal, is a way to kind of provide for the lowest income in our state some type of coverage. Now, anybody who's experienced Medi-Cal knows that there are limitations that Medi-Cal has. Not all doctors will accept it, especially when we get out in the rural areas, outside of the big metros of LA, San Francisco, San Diego, even Sacramento. When you get outside of those big metro areas, Medi-Cal doctors become pretty sparse. But I could see California essentially making Medi-Cal as the backup to private. If you are not on a private plan yourself, or you are not on your employer's private plan, everybody else gets thrown into the Medi-Cal system. I think that's probably where they want to go, but there's still a long way to get there. Having everybody to qualify, who isn't in a private plan, qualify for the state plan.
Because it comes down to the cost, right? People could go buy health insurance right now if they want to, or at the open enrollment they could have, but it comes down to the cost. If they don't qualify for the subsidy, then the price might price them out of the market, so they still have the option to have enrolled in January 1st, but the cost might have been prohibitive for them to do so. So they have access, it's just the cost is still the issue.
I would tell you that's probably the case, and for many of you employers on the call, you know that for those wage earners that are kind of on the lower end, you know, anytime, even if you're willing to pay for a good portion of their health insurance, if they have to pay for anything, they don't want it. And so, you know, that is an issue. A lot of you got employers are trying to provide a good quality benefit, and you know, anytime that the employee has to pay anything, it can be a challenge to get people to participate. And so you're right, Ned. I mean, right now, you know, most people do have the offering to them for some type of care, but there's still about 7% of the state who are uninsured.
What percent?
I would argue that I think about 7% of the state is uninsured at the moment, and I would argue that I think a majority of that 7%, probably 80%, probably is being offered some type of coverage. Even those folks who are undocumented, still working here, a lot of times they're still being offered the coverage. They just choose not to buy it because of the cost.
Yeah. Okay. If you have any additional questions, type those in. We're going to go to one last slide, which is just kind of talking about, you know, what are some options, and most of you have probably heard of these, but we'll at least kind of speak to them. Health reimbursement arrangements. Once your group is over, I'd say 25 employees, health reimbursement arrangements really are something that need to be looked at. We have several clients and several of you on this call who are participating in these plans, and the idea is, instead of buying a gold or platinum level plan and paying a higher premium, we put all the employees on a bronze plan, lower the premium significantly, and then take that savings and reimburse employees as they use the healthcare. So typically, the savings that you experience over the course of a year, even if you reimburse the employees for their medical expenses up to a certain dollar amount, you're still saving in the overall cost. So that's how health reimbursements arrangements work. And most of you know about these, but again, we can always look at them at your renewal. And so the reference-based pricing is a bit of a new concept, which we have not done much with, but Dave's office has. And so I'd like Dave just to introduce the idea to you, as this might become more popular over time.
And I know we brought this up last year, but essentially reference-based pricing is a kind of alternative to the PPO model that we see currently, where insurance companies are going out and they're negotiating with providers, you know, kind of a lower rate than off the streets. And what reference-based pricing does is saying, okay, rather than start with what they're charging on the street and then working down, let's use what the government pays through Medicare as our starting point and then work up. And so reference-based pricing is something that is being used through parts of the country and is becoming more popular in California. And it's kind of provides a lot more freedom to consumers of healthcare, because it kind of takes away the whole, are you in network or are you out of network? And it just says, hey, the insurance I have will pay you a percentage above Medicare. Is that something that you will accept? And since 90% of doctors and hospitals in this country do accept Medicare, it's a pretty good point, negotiating point to start with, to kind of reduce the cost of care. And I would tell you, Ned, that's the elevator pitch version of reference-based pricing.
Yeah. So let me ask this: what type of business is reference-based pricing? What business should be looking at that?
So currently, reference-based pricing is only available to those groups who are self-funding. Typically self-funded groups are those who are a little bit larger. When I say larger, anywhere from, 50 employees participating, but typically we're talking about 100 or more. That's not always, it doesn't have to be that case. There's lots of variables, and we can have that discussion if that's something you want to explore down the road. But right now, in order to use a reference-based pricing model, the employer group would have to be self-funded.
Got it. Another options that we see and we're hearing a lot more about is the health co-ops. So these are typically Christian sharing groups where it is not insurance, but it's groups of people who have opted out of health insurance and instead share their money when medical needs come up. So an example is, my barn burns down and all my neighbors bring, their tools and their wood and their hammers and nails, and we come and rebuild my barn. So I like the concept. I think that it is a great alternative for, say, a family who would qualify for it. I will say though that, like, just yesterday I got a call from a friend who happens to be on one of these sharing ministry plans, and he said, hey, my kid is on needing this medication every month now, and the co-op, they only cover it for 120 days. And so, and the example is, the co-op's not going to pay for maintenance medication. So now this family, he opted out of his employer medical plan and went on one of these co-ops, and now he's going to have to pay $200 a month for a prescription because it's going to be a maintenance prescription ongoing, where the health co-ops only cover if I get injured and I need a prescription for up to 120 days. It's not going to be ongoing. So it's not insurance. It is an alternative, and it's something that I do bring up at times where I have like a sole proprietor, and it's just his family, and their Kaiser premium or Western Health premium went up to $2,200 a month. This would be an alternative for them to look at, but it definitely is not for everybody. Dave, would you, association plans have been, kind of in the media as this savior that's going to be here. Can you speak to association plans in California?
What you're hearing on the federal side probably isn't really going to fly in California. California passed legislation back in the 90s that kind of severely limits association health plans. I'll just say that essentially, if an association wants to band together and provide their members with their own insurance and kind of fund it themselves, which is typically what you're talking about when they say association health plans, the amount that a group would basically have to come up with in reserves is prohibitive for most associations doing that. You really have to be an insurance company. And the reason why is because back in the 80s and the 90s, a lot of those association health plans, or what they used to call MEWAs, went belly up because they weren't funding themselves enough, and there were a lot of employers that were stuck holding bills when they went into these association health plans. So I don't see that. There's no reason to believe that the laws are going to change in California. However, I will say that what associations can do is they can bind together and participate in a fully insured large group plan in some cases. And then the question is, okay, so essentially an association says, hey, Anthem Blue Cross, United Healthcare, we're going to band together and we're going to get fully insured large group rates. Well, how attractive / beneficial is that? Because who's going to join association health plans? If you're a true employer group, you can go out and get your own health care, right, or group plan. So who's going to join these association plans? Those that typically aren't getting good rates by themselves because they're typically a little bit sicker. So they're going to join association large group plans, and large group plans do rate based on the claims data of that their own pool. And so I guess for those that have kind of seen this, we kind of look at this and go, well, okay, so sick groups are going to join association health plans on the large group side, and eventually they're going to the rates on that association plan are going to be higher than what they can get on the streets because of how those groups are going to run. I mean, that's how it's happened every time these things have happened in the past. That's essentially what occurs. Is healthy groups always go and find the lowest cost for themselves because they're healthy. Sick groups try to find whatever the lowest cost is that they can do, and if it's eventually over time the claims data says the healthy groups move away and do their own thing, and so sick groups stay, and the rates end up not being anything better than what they could have found themselves. So you will see some association plans, but I guess we're just recommending that don't hold your breath on it as like it's going to solve issues. In other states, I think it might, but in California, I don't really think it's going to be a big play.
Great. Thank you, Dave. Well, this brings us really to the end of our webinar, talking about legislation and our trip to DC and what we see going to happen in the state. If there's any additional questions, we'll stay on for a few minutes, and you could type your question in and we'll speak to it. But I just want to thank everybody for joining our webinar this morning. Thank you for putting your trust into Eureka Insurance Solutions to provide your employee benefit needs. We are going to do our HR compliance breakfast on August 22nd. So if you want to just kind of mark your calendar, but you'll see a save the date go out soon. I know that's pretty far out, but we want to get that on your calendars. And so that'll be an in-person. We'll have Sutter and Kaiser and Western Health and some of the other providers that we work with there, as well as Trevor from Palmer Kazanjian, who's spoken at our other HR compliance breakfast. So thank you all for joining, and then I'm just going to go ahead and see if there's any questions. Have a great day, everyone. One of the questions was if the recording will be available. Yes, we have the recording. I started it about 3 minutes into it, so you'll just miss kind of the introduction part, but we'll get that out to everyone.
No other questions?
No, I don't see any coming in. I think you're free to go, Dave.
Well, I'll hold on for just a minute until we kind of close the whole thing off. I see some folks are leaving, but just in case anybody else does want to ask, I'll wait until we finish.
Okay, we're going to go ahead and close the webinar. Thanks again, everybody. Have a great day. Thanks, Dave.
All right. Talk to you later.
Bye.
Bye.